excited to be talking to your group, and thanks for the introduction. And this is not my notes. This is, you can see the full screen. Okay, cool. Um, so yeah, so I've had an interest in group therapy for a long time. I initially, before I went to medical school, I was a theater major and thought I was going to be doing theater for my whole life. And there was a lot of group process and group co-creation. And for me, it was a very, I think, my first experience with um, a therapeutic process that involved a group. And we just finished, I guess, last year, a group MDMA-assisted therapy study, and I pulled a lot from my theater background, just thinking about, group process and group dynamics that can happen. And I think one of the main points of the talk today is just like how we think about psychedelics sort of amplifying and accelerating therapeutic processes when we're working with individuals. We've seen in our studies that psychedelics, when added to a group process, can amplify and accelerate group process. And so it's important to kind of be aware of what those some of those group processes are, because once you add the psilocybin or the MDMA to the mix, you're going to want people who know what's going on, because it starts happening in a very intensive way. Um, let's see. So I'm primarily at the Portland VA. I was at the San Francisco VA for 10 years before that. And I'm associate professor of psychiatry at the Oregon Health and Science University. This is a disclaimer that the VA makes me put on every talk, which is just that MDMA psilocybin not FDA approved yet. Probably not a surprise to anybody here. Um, but starting just with this context, so the process of gathering in groups with a healing intention and entering into what we might call non-ordinary states of consciousness is really universal. And it's a human phenomenon that spans cultures and spans time. And this is both with and without psychedelics. In the group, sort of what we could call therapeutic or healing, I think comes in many forms. There's sort of spiritual or religious containers, recreational containers, therapeutic containers, wellness containers. And so just thinking about kind of all of these different things. Um, and even when I talk about psychedelic assisted therapy, the sort of status quo, at least in the research, has been to work with co-therapy dyads. And so I like to even think about, when I work on an individual psychedelic trial, if we're working within co-therapy dyads, that's kind of a small group, right? It's a group of three, and we already get different dynamics than we get with one-on-one therapeutic work. And so I don't know, looking at these pictures and thinking, a rave is probably not the same thing as a Santa Daime ceremony. A psilocybin wellness retreat in Jamaica is maybe not the same thing as adding psilocybin to a long-term process group. People who have been meeting together in a closed, time-limited group for months and months and years. There's probably a lot of overlap between these different sets and settings, but potentially different intentions, different risks, different benefits to think about. And so I'm going to try to focus on group therapy, but even the term group therapy, I think, is hard to define. And so, what do we think about generally when we think about group therapy? Typically, group cohorts made up of 4 to 12 participants, often co-facilitated by a dyad. And when I'm training psychedelic therapists, I often hear from them that the only other experience they've had working in co-therapy dyads is when facilitating groups, which many of us have in training. So that's sort of an experience to kind of work with a co-therapist. Um, and then this sort of vague term, I think there are some sort of helpful frameworks. The American Group Psychotherapy Association has some really helpful tools. But thinking about terms like open versus closed. So an open group is like a drop-in group or a group with rolling admission, where if you take a slice of that group at one point in time and then fast forward 6 months, it may be, totally different people in the group, or different groups that during different sessions have different members, versus a closed group where it's the same pre-selected members throughout the duration of the group. And if you do add a group member or a group member leaves, there's a lot of sort of attention on that. And then open-ended versus time-limited is more about the duration. So an open-ended group is more long-term, thinking of like a Yalom-esque process group that maybe can sometimes go on for years. Versus time-limited, which primarily in the research world, we're working in time-limited protocols. We only have a certain number of weeks, a certain number of sessions. And then I work in the VA, and we have episodes of care. And so oftentimes our groups in the VA also are time-limited. Like it's a 12-week cognitive processing therapy group, or an 8-week motivational interviewing group or something. And then as far as modality, there's lots and lots and lots of different types of group therapy. And I think what's referred to as group therapy tends to fall on a spectrum. On one end, we have psychoeducation groups. I know Kaiser, does a lot of group therapy in sort of a psychoeducation format, which can almost be more like a classroom style, with a facilitator maybe doing psychosocial skills training or mindfulness practices with either no interaction among the participants or very little interaction among the participants, all the way to a psychotherapy group. I've kind of mentioned like more of a kind of open-ended process group. But usually psychotherapy groups are facilitated by mental health professionals. They use a specific modality to address psychological issues. And with professional facilitation, the group often explores kind of more deeply, delves into more like interpersonal dynamics, therapeutic change. And so it's often encouraged interaction between the group members. And I've heard, really experienced group therapists say that it's kind of their goal to get a group to be self-functioning. And if the facilitator doesn't really have to step in much, that's kind of how they want the group to run. But it does oftentimes take some time to get to that point for a group to develop enough cohesion and rapport. And then in the middle between psychoeducation groups and psychotherapy groups, we have things like support groups. Support groups might be peer-led, or led by someone with lived experience. Thinking of like an AA group, or some just using kind of a framework of supportive psychotherapy where there's not necessarily like an intervention. And then this question kind of comes up frequently in my work, and I don't necessarily have an answer for it. I think my answer changes all the time, but is a psychedelic retreat group therapy? And I think that, there's lots of different types of psychedelic retreats, and it may depend on, who's facilitating the group, where the group is being facilitated at, who the participants are. But it's a kind of a question that I bat around quite a bit. But I think, getting into semantics here, but really I think it's these different variables that determine how a group container is held. So is there a talking stick and rules about no cross talking, or is the group container sort of broad enough that participants are interacting more organically? And then you're allowing people to, as Yalom says, recapitulate their family dynamics in a way that can be corrective. And so when I'm designing a group study, I consider things like the duration of the group, the number and structure of the sessions, the cohesion of its members. So if I have a shorter time-limited group, I usually will want to start with a more homogeneous group of participants so that they start off with a fair amount of cohesion. So combat veterans, long-term AIDS survivors. Whereas if you're planning a long-term process group and you have the luxury of time and you have the luxury for things to kind of organically unfold, you actually may want the richness of a more heterogeneous group. So, different genders, different diagnoses, different life experiences. Um, and then some of these different variables and will determine what the theoretical framework you use, what the qualifications of your facilitators are, what the criteria are for to be a participant in the group. So just some things to think about, and I think that um, any group therapy, whether it has a psychedelic or not, should really tailor a lot of these variables to the population that you're aiming to serve. And so I don't think there should be kind of one way to do group therapy. I think changing some of these variables will just change how the group is run or who can be in the group. But I think a variety of groups are needed. This is a systematic review that I worked on looking at psychedelic assisted group therapy, primarily in the 1950s through the 1970s. And so this was kind of pre-Controlled Substances Act, pre-prohibition of psychedelics. There is a group in here referenced in the Switzerland group, and that's the group from 1995. They were able to run groups in sort of an expanded access model, but otherwise these are all psychedelic group therapies that happened before the Controlled Substances Act. There were 12 studies that we found, about 700 participants total. A mixture, mostly LSD, some psilocybin, and I think the Swiss group did MDMA and LSD. But looking at these earlier groups, I think in general, sort of the clinical trial methodology didn't have the same rigor as it does today. A lot of these studies, had things that we're still struggling with, like lack of blinding, not enough for funding for a control group. But they also had some interesting variables here. So there were certain groups, like if you look at the fourth column over, this is the criteria for being in the group. And so this top group included people with schizophrenia, schizoid states, depression, anxiety, hysteria, which was a term they were still using, and psychopaths. And so those were just kind of all people that were in the group together, which I think is pretty interesting. Then down like the third row, they included neurotics, people with anxiety and neurosis and phobias, characteropathologies, homosexuality, psychosomatic problems, which include migraine, dyspareunia, premature ejaculation, and hysteria. So these must have been very interesting groups. But then it got us starting to think too about the different ways that you can add psychedelic administration to a group framework. So some of these studies did administration of psychedelics in a group format. Some of them had sort of group therapy and then individual administration. And we learned a lot about what happened. And then with Brian Anderson at UCSF, we designed and ran the first psychedelic group therapy study of this century, which happened, I think we ran the study in like 2018 at UCSF. Initially, we wanted to work with cancer patients and kind of go off of some of the earlier psychedelic studies from like the early 2000s, like Hopkins and NYU and UCLA. But a lot of us had worked with this population in San Francisco of long-term AIDS survivors. And so this is primarily older gay men who had been diagnosed with AIDS in the late 80s or early 90s. And this was before antiretrovirals came out. And so they had lost a lot of people. They lost partners and friends. A lot of them were on their deathbeds. And then antiretrovirals came out and essentially saved their lives, but they continued to sort of carry this trauma and this existential dread for decades, which was kind of limiting to their functioning. A lot of them had depression and anxiety and PTSD symptoms. Um, and one thing that we thought we didn't realize until we started the study, but there was a framework among this population for what we were doing, bringing psilocybin and, trying to move these psychedelics through the FDA drug development process and um, help more people have more access to them in a healing environment. If you look here, this is from sort of the early AIDS epidemic. The third picture over is from a die-in on the steps of the FDA, where essentially they were, pressuring the FDA to acknowledge that this was a thing and to get antiretrovirals through the drug development process and available for people. And interestingly, after the FDA decided not to approve MDMA, there was a similar demonstration with veterans in front of the U.S. Capitol, where I think they had 150,000 dog tags, and they did a demonstration, and the dog tags represented all the veterans who had died of suicide while we continue to determine whether or not these interventions are safe and effective. So I just thought that was kind of an interesting piece of this, but we were more conservative when we thought about the design of this trial. And so it's a group therapy study. There's one psilocybin dosing session. We were dosing by weight still at that point. And the psilocybin dosing session was individual. And so we would start off with an individual prep just to kind of orient them to the model, answer their questions. And there was a lot of resistance too to this being a group modality. A lot of the participants said that just other long-term AIDS survivors were triggering to them, and a lot of them avoided, neighborhoods that they had hung out in the 80s and 90s, and they avoided other people who kind of reminded them of that time period. So there was a lot of resistance going into this as a group model. So we did an individual preparation first, and then we did 4 90-minute group preparation sessions. And we used supportive expressive group therapy as a framework. And this is a modality that's used a lot with cancer patients, and it really aligns well with the sort of inner-directed, non-directive psychedelic therapy modality. And then everybody would take a 2-week break, and we had 6 participants in each cohort, and someone would come in on a Monday, and they would have their individual integration the next day, and then the next person would come in that Wednesday and have an integration Thursday, and another person would come in Friday. And then they would all go back to the group for 6 additional group integration sessions. And we were really pleased to see that by the end of the group, these men were there was a lot of cohesion. They were on group text threads together. We heard, months later that some of the cohorts had gone on vacation together, which is, I think, a good outcome. And then at the 3-month follow-up, we looked at our primary outcome was the demoralization scale, and so we didn't want to necessarily restrict this to specific diagnoses, and we also didn't necessarily want to look at this study through the framework of the DSM, even though that's what the FDA wants to see. And so our primary inclusion criteria was a certain score on the demoralization scale, which is a measure used in the cancer world a lot, but it's sort of this sense of helplessness and hopelessness, and they had to have a certain score to be included in the study. And then they could have depression or PTSD or an anxiety disorder, but that wasn't required for inclusion in the study. And then the score on the demoralization scale was also our primary outcome. And we did see a large effect size and significant reduction in demoralization at the end. This was also one of the first clinical trials to show a reduction in PTSD symptoms. We did just sort of self-report PCL5. And now there's with psilocybin specifically, and I think there are now a couple of pilot studies looking at psilocybin for PTSD, even though out in the world we know that this is helping people. We're just starting to see that in clinical trial data. So that's that study. And then I'm going to kind of quickly go through our MDMA study. But looking back into the literature, early MDMA groups.
Hey, Chris,
Yeah.
I'm so sorry, but before you go on, there's one brief question in the chat asking about the length of the phases. So for the study that you just described, how long did the
Mm.
preparatory phase go on? How long did the integration phase go on as far as the official intervention went?
Oh, good question. Thank you. So these preparation and integration visits, the yellow dots were a week apart. So it was, 1, 2, 3, 4, 5, 6, 7, 8, 9. It's like 10 to 12 weeks. It was kind of the course of the intervention.
Thank you.
Mhm. Yeah, and so this is just kind of looking back at early MDMA work. Groups was sort of a thing that developed organically. And there were different types of groups. So Leo Zeff um, preferred this sort of parallel individual group. I like this quote from him. Sometimes people like to get up and do some hugging, and then we set them right back down. So it was, very strict sort of, you're doing your own inner work on your own mat. I think a lot of ayahuasca ceremonies are run in this way. And then others, like Claudio Naranjo, uh, liked more of a interaction during the dosing session. So there was structured interaction where people either took turns talking. They had like a talking stick, so people weren't talking at the same time, or there was some sort of like facilitated structured interaction during dosing, or unstructured interaction. And the unstructured interaction groups typically were people who had pre-existing relationships, either coworkers or family members, or people who knew each other well, or put more into this frame of unstructured interaction, or people who had more experience with MDMA. I know usually with if people didn't have experience, then the more parallel individual was preferred. And this is a publication from the group in Switzerland. They did long-term group therapy with mostly with complex PTSD, and they would do a couple of dosing sessions per year, and in between there was a lot of integration, and then people would sort of move on from MDMA once they felt safe and familiar and comfortable enough with the process to LSD, which was thought to sort of deepen the process, but they wouldn't start with the classic psychedelic. They would start with the MDMA. But these groups would go on over years, which I think is really interesting. If you want to know more about our MDMA group protocol, we have it published in the Cognitive and Behavioral Practice, so you can look it up there. Um, let's see, I'm seeing another question here for the AIDS survivor group. Oh, thank you, Maya. Yeah, that's right. Yeah, and typically for our studies now, we're using 25 to 30 milligrams, just kind of standard, not weight-based.
And
Um,
Chris, you don't need to try to monitor the chat. I'm going to take care of it and I'll mostly do questions at the end.
okay, sounds good. Um, So this is just to show for the MDMA group, we combined the MAPS manual with the manual for present-centered group therapy, and I think this has an interesting history. Present-centered group therapy was developed through VA research as a comparator to trauma-focused group therapy, and so they wanted a group therapy that sort of had all the elements of a group therapy, but wasn't doing prolonged exposure or cognitive processing during the group. And what they found was that present-centered group therapy, which was kind of modeled off of Irving Yalom's 11 or 12 unique characteristics of group therapy. But it was present-centered. They didn't do any trauma processing. It was more just kind of how are your PTSD symptoms affecting you right now. And they found that the outcomes were comparable. So people were reducing PTSD symptoms just as much in this present-centered group therapy comparator arm than they were the trauma-focused group therapy, and that people were staying in the present-centered group therapy more. So there was less dropout. And we know at the VA now with individual prolonged exposure and cognitive processing therapy, there's like a 50% dropout rate. And a lot of people just say that it's too emotionally intense and they don't have enough therapeutic rapport with their provider to do that difficult of work. And so present-centered group therapy, similar outcomes, much higher retention, and we felt like it was a really good fit with the sort of inner-directed approach with MDMA assisted therapy. And this was our protocol. We had a 3-month screening period to get enough people for a 6-person group cohort. And then we started this study with group prep, and this was groups of veterans. We did groups of either combat veterans or groups of veterans who had experienced military sexual trauma. And everybody had one individual prep, V4, but all the rest of the prep were group. And then V6 and V7 was their first dosing session. It was individual. So they all got an individual MDMA dosing session with the next morning individual integration session. And then all the rest of the visits were group. So they came back to the group, did more group integration, then a group dosing session, which was conducted like the parallel dosing, where everybody was instructed to stay on their own mat and interact only with the facilitators or the therapists, and then 4 group integration sessions. And you can see we had teams of 4 therapists, so we had facilitator teams of 4, but you can see through most of the visits, it was only 2 people present. So there were 2 kind of primary group therapists, and then for the individual sessions, those 2 group therapists split up and were joined by another person. And so all the individual sessions had 2 co-facilitator dyads. And we had a pretty interdisciplinary team. So we had psychiatrists and psychologists and therapists, and every group cohort also on the team of 4 included a veteran peer specialist, which was, the veterans were really appreciated, and I think helped us a lot with like rapport and retention and buy into the model. This is a publication that we did just on the cost effectiveness of our group model compared to if we did individual MDMA session. You know, no surprise, we saved a bunch of money on clinician time and cost. And we ended up enrolling 18 people initially. And this paper should be coming out soon, so you'll be able to see these once they get published. This was our primary clinical outcome, was the CAPS, which was administered by an external group of raters who were blinded to the study, so they didn't even know what study they were doing CAPS assessments for, what time point compared to the intervention. And you can see there's a large effect size. You can see 13 of the 18 had clinically significant response, 12 lost their PTSD diagnosis, and 3 of them down here were in remission, which means their CAPS score was 8 or less. Sheehan Disability Scale, significant, large reduction in disability and increase in functionality, and the same large decrease in depression. One thing that I thought was interesting, so after each dosing session, we did the challenging experience questionnaire, which was developed initially for psilocybin work at Hopkins with Fred Barrett. And these are the subscales: fear, insanity, paranoia, grief, isolation, physical distress, and death. And we didn't really see a difference between the individual and group dosing sessions as far as how challenging, at least a significant difference. You can see there's, some slight differences, but it's also hard to say if some of these changes are because it was their second time dosing or if it was because it was a group environment. We're not really able to say. But one thing that we thought was interesting was we compared the strength of the challenge, like how challenging a session was, to how much their PTSD scores changed. And when we looked at the individual session, there was no correlation at all. So how challenging their session was, it had no bearing on how much their PTSD reduced. But when we looked at the group session, more challenging experiences meant that their PTSD scores changed less. And you can see that the three people with the most challenging experiences didn't really change at all in their PTSD symptoms. So there may be something there to people experiencing challenge in a group environment that is maybe counterproductive as far as the therapeutic quality. But there's more to explore there. And then we did a fourth cohort where we added another treatment cycle. This was pretty much across the board. All 18 participants said, we wish we could have had another group dosing session. We feel like we just got the chance to sort of see what it was like, and then we felt like we could do a lot more therapeutic work if we had one more group dosing session. This was all a group of transgender veterans. And you can see here is their CAPS scores and then their self-report PCL scores. And the green dotted lines are where the MDMA dosing sessions took place. But now just shifting gears a little bit, I like this quote from Eric Byrne. He wrote a book on group therapy in the 60s. Knowledge of group dynamics for a group leader is as essential as knowledge of physiology for a physician. And interestingly, Eric Byrne was influenced by Timothy Leary, and Timothy Leary wrote his doctoral dissertation at Berkeley on the social dimensions of personality, group structure, and process. And I like this quote from Timothy Leary. He wrote in 1947, when he was doing his doctoral dissertation, a medically trained psychiatrist considered group therapy as recklessly dangerous as requesting a group of patients to perform perilous surgical operations on each other. So I think how we think about groups and what we know about groups and how we kind of hold and conduct groups has really evolved since the 40s and even since the 60s. There's been a lot of sort of development. I don't know how many of you who are interested in group therapy have what I hear a lot of people call the group therapy Bible, is Yalom's sort of big book in group psychotherapy. But with my research group, we came up with this little mnemonic of basically the 4 codes of things to consider when you're running group psychedelic therapy. The first is consent. And so starting with individual informed consent, but really considering consent an ongoing process that applies in multiple ways. So thinking about, psychoeducation, primarily during preparation, we would use a motivational interviewing strategy called elicit, provide, elicit. Like we would never just start talking at them. We would ask the group's consent if we could provide them with some information, which is the first elicit, and then we would provide the information, and then we would elicit their response and basically hand the group back to them and say, like, how does that sit with you? What do you think about that? We had a pretty standardized process around touch and consent for touch. And this is something that we did during our individual preparation sessions for each individual dosing session. And then we had another kind of re-consent process with the group before the group dosing session around touch and needing to address sort of participant to participant boundaries around touch. And then for people who have experienced spiritual abuse or harms within organized groups, we got feedback early on that even things like leading group mindfulness exercises, at the opening of a session where we're inviting people to close their eyes and using our voice to sort of walk them through a guided meditation, that was triggering to some folks and maybe overwhelming. And so we really took care to meet the group where they were at, and being kind of extra aware of how engaged each person was in the consenting process, and being aware of things like groupthink and peer pressure, and really wanting everybody to feel comfortable. And that kind of goes into the next, which is container, which is kind of a beyond sort of psychoanalytic term. But holding the group container, I think, really is the job of the facilitators. And one thing that came up over and over again with new psychedelic facilitators, particularly with the MAPS model, where we talk about the inner-directed process or non-directed process, that holding the container of the group can't be a non-directive process. Like it takes energy for the group facilitators to really establish safety, establish structure, and create a supportive environment. And then once that framework is established, the participants can fill it in whatever ways they want. But the creation of the container and the framework really needed to be an active process of the facilitators. And so that we noticed that was sort of people were kind of over-interpreting the inner-directed, non-directive approach, and this was something where we felt like that didn't necessarily apply as much. And so, yeah, the facilitators really set the tone, and they need to stay attuned and really intervene when necessary, especially at the beginning of the group. This was kind of more important during preparation, where the group's members were still getting to know each other, but sometimes needed to step in and facilitate group dynamics. So helping the group navigate conflict or tensions that arise, slowing things down, ensuring that everybody had a voice. And then as the group progressed, they didn't need to do that as much. And we did notice that once MDMA sessions started happening, even the individual ones, the group process really jumped forward quite a bit. And so we would see, from week 4 to week 6, and in between that, the individual MDMA therapy sessions happened. It felt like the group, jumped forward like 9 months, as far as the way they were working together and their cohesion, which I thought was really cool. And then in the first group preparation session, essentially right after introductions, we have a process for setting group guidelines. And you want to make sure, and this can be different for different groups, but how do you handle trauma processing in the group setting? How are you thinking about relationships outside of the group container? And we really wanted to do this so going to the third thing here is co-creation. We asked for group guidelines to come from the participants, and we had sort of a list in the back of our mind of things that we wanted. I think the things that we wanted were like obvious things like confidentiality, but really wanting the group guidelines to come from each cohort. And so each cohort had slightly different guidelines and slightly different ways that they were thinking about things. And then similarly, co-creating ritual and ceremony in the group container, and what sort of rituals are we setting up at the beginning so that by the time we get to the group dosing session, there's a sort of way that they start group and a way that they end group. And I think some like symbology can happen. There was one group where they wanted to know during their introductions, they came up with the question of what animal would you be and why? And then somebody brought, in a later preparation session, little animal figurines of everybody's animal. And then everybody's animal would be basically on the altar for everybody's individual session. And so it was like the group was with them. And then, they brought the animals into the group dosing session. And it ended up being a really sweet part of that group cohort that just came from the group. And so it's not necessarily something that the facilitators had to bring in and facilitate. And then cohesion is the last one. So group cohesion has different definitions, but the sort of group therapy definition is it's kind of the group version of therapeutic alliance. And so it's, agreement on goals, agreement on the methods for achieving those goals, and trust. And it's not just between the participants and the therapists or the facilitators, but among the participants, and then thinking about the group as a whole. And that makes up group cohesion. And then just like therapeutic alliance, group cohesion is linked to therapeutic outcomes. And then thinking specifically now, the 4 co's of challenges when you're thinking about psychedelics in groups. And so one that comes up frequently is comparing and contrasting. This seems to be sort of a natural tendency that after, particularly after individual, but can happen after group too, when participants start hearing about other participants' experiences, they automatically start comparing their experience to others. And we'll hear and see in the same group, like somebody who maybe talked a lot during their session is looking at somebody who was inside the whole time and saying, well, why couldn't I have been inside the whole time? And then at the same time, the person who was inside the whole time is like, well, why didn't I talk more? And why didn't I get this opportunity to like process things? And so they'll start to do that with each other. And so we started to address it during preparation to just kind of prepare people that that might be something that comes up and to really encourage them to stay with their process and then to notice what's coming up. You know, what are they noticing about other people's experiences, and what how is it applying to theirs? But I think just having an awareness that that might be something that comes up actually helped smooth it out. um, and let's see, concretize. So concretize, I think just like we see on social media nowadays, the group mind, especially like earlier groups, kind of deal with group anxieties by polarizing things. And so they'll particularly polarize things into good or bad or right and wrong. And so, you know, similar thing, like if we start to get to talking and everybody's talking about what their experience was like, suddenly the group will start making rules about like, oh, okay, so being inside the whole time is good and not being able to go inside is bad. And the group will just start to like create these rules. And so you as a facilitator have to just point it out and be curious about it and, you know, ask the group, is that really true? Or like, let's think about that a little bit more. And then usually if you just express curiosity, the group will it'll kind of bubble back up into group consciousness and not turn into something that could potentially be harmful for individuals if the group isn't really thinking about it. Um, Compromise. This is just, you know, very basic logistics. Is you're compromising time and attention in a group setting. So, you know, in our study, we went from individual dosing sessions where there were two people attending to your like every breath, and then going to a group dosing session where there were 6 participants and 4 facilitators, and there wasn't the same sort of individualized attention. So just being aware of that. I don't think it was ever like a major issue, but it was something that we had to address a couple of times. Um, and I think there are also benefits to having, you know, being able to see the facilitators interacting with other people or being able to see other people's processes unfolding. Um, and then conflict too. So conflict within the group can be incredibly productive, incredibly healing, just like rupture and repair and individual work. You know, the sort of rupture and repair process in the group among participants, or even, you know, between a participant and a facilitator, can be really healing for the whole group. And I think it needs to be carefully facilitated, because rupture that isn't repaired can have negative consequences on the group as a whole. And it's a little bit different in a group. Like I think sometimes, especially like I said early on in a group, the conflict may need to be facilitated a little more, or kind of modeled, of how we do conflict resolution in the group setting. And then just like how we talk about inner healing intelligence for individual work, I also, I think, see time and time again this group healing intelligence, and really being able to trust that a group of individuals um, from that group is going to emerge predictable relational patterns. And uh, Really, I think a lot of times we have this anxiety as group facilitators that it's just going to be chaos, but then you start to see that there are these, it's almost like sacred geometry starts to form in the group. And, you know, there are these sort of cohesive structures and patterns that start to emerge without you having to micromanage as much as you may have worried that you would have to. Um, and also, I think being aware, a lot of times I hear this from VA regulators or VA policymakers, like, oh, the group, that's great. You're basically just getting 6 people in at the same time. And I kind of constantly have to remind them that a cohort of 6 participants oh, isn't just 6 individual treatments kind of crammed in for cost effectiveness, that there's actually something happening uniquely in a group setting. And I think it's uniquely therapeutic, and then there are also unique risks to consider and think about. But it really is its own modality. And another thing is, there will be group process happening even when you're instructing people to do inner work on their own mats and interact only with the facilitators. There is a florid, rich group process happening. And I think it's a beautiful thing, but something that you have to be aware of, and know how you're going to hold that container. And I think the last point is just that the protocols I showed, those are specific protocols, but I think there's lots and lots of room to expand and explore different options, different protocols, different ways of mixing and matching group therapy components with psychedelic dosing. Um, and oh, that's it looks like that's the first point of my conclusion. And then psychedelic group therapy is proving to be feasible, and we need to understand more about unique risks, who's best suited for groups versus individual, and whether group is you know, as effective, or even some maybe possibly more effective than individual work. And then this is our space. I think this was from our very first group MDMA dosing session at the Portland VA. But looks like we have some time for discussion and questions, and I'm
Yeah, that was
curious.
wonderful, Dr. Stauffer. Thank you so much. I think we're going to go to some of the questions in the chat, or if anybody has questions they'd like to ask directly, if you would just raise your hand, and then we'll go in order.
Sure. Yeah. Thank you so much. And there are a few questions. Some of these are pretty simple, so I'll start with the straightforward ones. You mentioned early on about the different approaches to group therapy, including the more inner-directed or parallel versus structured and unstructured groups interacting together. To your knowledge, have you what would be the process of maybe a combination of using both structured and unstructured, and how that might play out in the group dynamics, and maybe in what settings would that be the most appropriate?
Yeah, that's a really good question. And I think, it depends on who your facilitators are and what the context is. I will say that in our MDMA group study, like I said, all the participants were like, if we could just have one more session. For the cohort that did have a second group dosing session, you could tell that people were kind of pushing the boundaries of what interaction amongst themselves looks like, and there was a little bit more of like, okay, now I'm talking to 2 people at the same time, and they're kind of interacting with each other. So I think that it was starting to happen organically with this group who had been working together for longer and had already had a group dosing session under their belt, that they wanted to be more interactive during the second dosing session.
Yeah, and I can imagine with something like MDMA that may be more likely to emerge rather than something perhaps like psilocybin. And so there were some questions about the types of group dynamic conflicts. You mentioned a few. Are there any in particular any patterns that you saw, things that seemed to develop more frequently?
Yeah, I mean, I start thinking about this from the very beginning as we're screening people and assembling a group cohort. I can't remember who calls it this, but I like the term fault lines. Like, you think of fault lines as potential for um, sort of subgrouping and scapegoating. And so if I'm putting together a group and I have, like 5 men and 1 woman, like that's a fault line that I either need to pay a really close attention to, or maybe consider, doing a cohort of women and having that person wait until the next cohort. And then thinking about sort of fault lines as a risk for subgrouping. And then once I identify subgrouping starting to happen, usually just bringing curious attention to it will kind of make it go away, essentially. But I think subgrouping can then become a risk for scapegoating, and scapegoating, depending on what sort of theoretical framework you're looking in, is sort of a group putting all of its anxieties into one person, and then usually the group will try to, like, get rid of that person, or that person will just leave, and then the group is kind of left feeling really good and feeling like they don't have any shadow work to do. And so I think if I see a group managing group anxieties in that way, there are all these kind of warning signs before you get to the point of no return. And so I think being aware of things like that can be really helpful.
Thank you. And then I'm going to invite Harrison Grace to ask his question. Harrison is a psychiatry resident. You can unmute and ask your question.
Hi, thank you. And let me know if any trouble hearing me. Um, Thank you again for the presentation. Definitely see much trauma in day-to-day clinical practice, and understanding its polymorphism and complexity of presentation, I can empathize. It's a challenging study topic as well. Not to mention interpersonally with group interactions. But just out of curiosity, preliminarily or anecdotally, any positive or negative correlations that you have noticed with individuals or groups that have more predominant perceptual disturbances from trauma etiologies, hyperarousal, even perceptual hallucinations and experiences like that. Just curious if like that has any, up or down with psilocybin or other assisted psychotherapies.
It's a good question. Um, what's coming to mind? I mean, we have right now a psilocybin therapy trial. It's not.
I don't have a terribly clear kind of like, um, you know, presupposition of what that response would be, but just a
Yeah.
curiosity of how those could interact.
Well, I think, distinguishing. We're always careful to distinguish
Oh,
a
I don't know if
primary.
I can
Oh, can
hear
you
you
hear
if
me?
it's a microphone issue on my end
You can't hear me?
or
Let's see.
sorry.
Try, Harrison, are you able to hear us? Because Chris is
Do you know?
answering.
Yeah,
Can you
Okay,
hear
go.
me?
I hear you. Thank you.
Okay. Um, yeah, so I mean, always trying to distinguish between like a primary psychotic disorder and PTSD symptoms
Thank you.
can be tricky, but I think that even things that look psychotic, if we're pretty sure that it's PTSD, tend to do well in these studies. And we have a study right now of psilocybin for veterans with methamphetamine use disorder, and it's people with severe addiction who are in a residential treatment setting. And we decided, because they're in a residential treatment setting and they have so much support while they're in the study, that we would not make stimulant-induced psychosis exclusionary. And so I think 75% of the people who have gotten psilocybin so far have a history of stimulant-induced psychosis, but we're pretty confident that they don't have, a primary psychotic disorder. And that has not so far not been an issue.
Okay, well, it's good to know. That
Yeah,
is indeed such a common comorbidity.
yeah. And then another thing I thought of while you were asking was, in relation to the group, uh, sort of the nature of people's trauma when it had more of an interpersonal complex trauma, especially the group with military sexual trauma.
Mm,
The group dosing environment was much more challenging. And so, a good amount of the people with the high challenge and the low reduction in PTSD were from that group cohort. And I think, we had a lot of cases where it seemed like they were really benefiting from the intervention. And then they had the group dosing session. And it's like all of their defenses came back online because they just didn't feel safe having their defenses stripped away and being that vulnerable in an environment where they couldn't track what everybody was doing. And so that's just another thing to sort of think about, is a history of like harm, interpersonal harm, or harm in groups.
Okay. That's a good point. Thank you. I can imagine that mechanism makes sense. And, even the positive sometimes, like you mentioned, group dynamic mechanism of kind of practicing and to some degree embracing and learning the safety of that group vulnerability can be its own issue in that case. Yeah. Cool. Thank you.
Thank you.
Well, that might be perfect timing. I think it's 6 o'clock, and appreciate everybody for showing up. And huge thank you to Dr. Stauffer for sharing your research with us and helping get our UNM psychedelic interest group back online.
Excellent. Well, thank you so much. Yeah, have a good night, everyone.